Good evening, friends. It gives me great pleasure to welcome you to this GINA guideline meeting being organized by the Indian Chess Society. I would like to thank Juventus Healthcare Limited for supporting this webinar. And I would also like to thank Science Integra for being the scientific partners for this meeting. My name is Dr. Rajadhar, and I work as Director, Department of Pulmonology, Fortis Hospital, Kolkata. I've got an elite panel of pulmonologists with me. I start off with introducing Dr. G.C. Khillani. Everyone knows Dr. Khillani. He is MD Pulmonary and Respiratory Medicine. Very recently, ex-head of Department of Pulmonology, AIIMS, New Delhi. And currently, he's the chairman, PSIR Institute of Pulmonology, Critical Care and Sleep Medicine, PSIR Hospital, New Delhi. My next panelist is Dr. Kumar Doshi. So before that, let me introduce someone who's actually not there, Dr. Rajesh Swarnakar. So Dr. Rajesh Swarnakar is very much a part of this panel. He is currently doing some other webinar and will join us during the question answer session from questions coming from the audience. However, he's pre-recorded the answers to some of the questions that I'm going to ask during the meeting. So Dr. Rajesh Swarnakar is the Secretary of the Indian Chess Society. He is the Chief Consultant Pulmonologist and Director, Getwell Hospital and Research Institute, Nagpur. The next person on this panel, dear friend, Dr. Kumar Doshi, who is a consulting interventional chest medicine and HOD chest medicine at the Asian Cancer Institute and the Somaya Super Specialty Center. And he's currently involved with treating a lot of COVIDs, like a lot of us are actually, at Somaya Hospital and Rajawadi hospitals. My close colleague and dear friend, Dr. Indranil Haldar, is the fourth individual on that panel. And he is a pulmonologist with TB and respiratory disease, wide experience. The other great thing about Indranil is that, unlike a lot of us, he is a pediatric pulmonologist with a special interest in that area. And currently, he's Associate Professor and Head of Department of Pulmonary Medicine in College of Medicine in Hospital, where he's also got a COVID hospital under him. So that's the panel we have. We are going through the midst of a pandemic, the COVID pandemic, and all of us, I'm sure, are affected and are participating in this pandemic in some way or the other. I'll start off the questions and answers with something which aligns COVID-19 with asthma. The questions that I'm going to ask over the next 45 odd minutes are questions which are based on the GINA 2019 and the very recently published GINA 2020 guidance. I want you to send me your questions. So if you can send the questions across on the chat box or on the link that's been given to you, the technical support team will send these questions through to me, and then we'll discuss them with the panel at the end of this meeting. So I'm looking forward to lots of questions from the people who've logged in. So I start off, like I said, with a question which links COVID-19 and asthma. And my first question is to Dr. Rajesh Swarnakar. Dr. Swarnakar, the GINA consensus about inhaled steroids and COVID-19 in patients with airways disease. So what I mean is both oral and inhaled steroids. What is the consensus about its use in patients who have asthma, both stable and exacerbating forms of asthma? Over to you, Rajesh.
Yes, Raja, there seems to be a confusion among physicians whether to use inhaled corticosteroids in COVID times, fearing that it will weaken the immune response required to fight COVID infection. But GINA, in its updated guidelines released amidst this the COVID pandemic on April 3, 2020, categorically says that patients with asthma should continue taking their prescribed asthma medications, and of course, particularly inhaled corticosteroids and even oral corticosteroids if it has been prescribed earlier.
Srimon, video is not visible.
Oral corticosteroids only for severe flare-ups and not for milder.
Sorry, are we still connected? I lost the voice there suddenly. So,
Patient.
right. I have lost Rajesh's voice for a minute, guys. I'm sorry. Bear with me. Can all of the remaining faculty hear me?
Yeah. Yes, yes.
Okay. So just very briefly, I think we lost Rajesh's voice for a minute there. I think the consensus is that inhaled steroids in airways disease, you continue the inhaled steroids the way it's being continued at the moment. Inhaled steroids are not known to increase viral replication or the viral load in these patients with the limited data we have today. The oral steroids, again, we know that it does increase viral replication in the upper airway. And hence, in an exacerbation scenario, what you do is to give them the lowest dose of steroid that you can in controlling the exacerbation. And that's true for both asthma and COPD. Is that fair to say, Kumar?
I would actually, Raja, simplify this whole asthma and the COVID confusion that do nothing different. Avoid nebulizations.
Absolutely.
Use the least possible dose of oral steroids if you have to use, but don't be wary of using it, because a person who is having an uncontrolled exacerbation of asthma, God forbid, if he gets a coronavirus infection, these are the ones who really do not do well. So controlling a disease is far more important than rather just getting scared. And more importantly, all of us who are treating COVID, we have been pretty liberal in using methylprednisolone for patients who are on COVID. So I think we should just say simply, do nothing different. Use least possible dose of oral steroids if you really need to give them. Avoid nebulizers.
Quick word from Dr. Khilani, please.
I would just a little note, the steroids should not be liberally used in COVID. As far as the exacerbation is concerned, whenever the COVID patient is not requiring admission, not requiring ICU care, the recommendation as far as the critical care part is concerned, that you give steroids only if they are indicated for the purpose of treating the critical illness, like the person is in septic shock or otherwise steroids. And steroids are immunosuppressants. Any condition, anything which immunosuppresses will have to have is logically can be thought to have adverse outcome with COVID. So it should, as you very
sir, your point is well taken. The only thing which I was correct, sir. Your point is well taken. The point which I was trying to get across is that we've had good results in patients who are having bad COVID disease with intractable hypoxemia and have been given prednisolone.
There's no question
Exactly.
about
So at that point in time, the point I'm trying to get across is that in case your asthma is in exacerbation, please do not worry about giving them oral steroids. If they deserve it, please give them, but the least possible. That is the point.
Can I just sort of end that argument there? I think all of us are saying the same thing.
Yeah.
What we're saying is that the steroid needs to be given when it's absolutely indicated.
Correct.
Be it for ARDS, be it for ILD, be it for asthma,
absolutely.
And we have to give it at the least possible dose with the understanding and the caution that you might increase viral replication by giving the steroid, but you balance that risk against the benefit that you get by asthma or the COPD exacerbation. I think that's sort of a bottom line there. Okay, so you've mentioned nebulization briefly, but I'll have to ask this question again to Rajesh, if that's okay. So Rajesh, again, similar to what you spoke about just now, and we heard you partly there, but what is the GINA consensus about nebulization in patients with airways disease during the COVID era?
Yes, some caution about nebulization is to be taken as it's aerosol generating procedure, with nebulization increasing the risk of disseminating the virus to other patients and to healthcare professionals. So in all, avoid nebulization where possible in a COVID suspect or confirmed case, and instead we can use pressurized meter dose inhalers via spacer, which should be the preferred treatment during severe exacerbations, with a mouthpiece or tightly fitting face mask if required. And its efficacy compares equally well as with nebulization and seems much safer.
Grand. So I think that's a very honest and fine answer. I just need to raise a couple of points. I think these are important questions, especially given the period we're going through. So I know we are all saying that nebulization is something that you avoid as far as possible. However, if you look at the recent the BTS guidance, they are asking you to continue using nebulization in a safe environment with the patient in a single room, even if you are COVID positive, especially in patients who are unwell. And you would have all seen the new nebulizers that have come in with the closed circuit in trying to nebulize these patients. We will continue to face this challenge with nebulization even after these lockdown periods and so on. So a quick take maybe from Indranil. Indranil, what's your take? Today, tomorrow, day after, even when this lockdown goes away, we will have the same problems with
Absolutely.
And what's your take?
Absolutely, Raja. And thanks to Rajesh, he has given the answer there. So nebulization is better to be avoided, knowing fully well that specialized metered dose inhaler with a spacer gives the same benefit. Wherever possible, we should switch over to a pressurized metered dose inhaler with a PMDI. Even if nebulization is to be given in situation, for example, home nebulization, or when the patient is admitted to our hospital, the best thing, there are different guidelines that the BTS has been coming up. The nebulization with a mouthpiece practically generates less aerosol. And even when a nebulization is being given, be it COVID positive or even if not knowingly whether the patient is COVID positive or negative, the person who will be entering the room, it should be in an isolation place, and healthcare personnel, when they enter the room, should be using the proper PPE kit.
Sure.
That's the thing. It should be good ventilated, and persons entering should have his own protection there.
Sure. So Indranil, I take your point. Dr. Khilani and Kumar, do you have a different take on this at all, or are we going along?
No,
Rajesh
no,
is saying?
my passion is intensive care, so I take you little there on the nebulization, nebulization front also. And even when the patient is on ventilator, it is advised and recommended that nebulization should not be used. If you want to give aerosol therapy, it should be given with meter dose inhaler with the use of a spacer. That is the standard recommendation. Because of the same analogy, the non-invasive ventilation is also not used because of the risk of generation of aerosol.
Sure.
It is true that, if you have a negative pressure ventilation, 12 exchanges per hour, where is that actually? One, that it is very rarely available and it doesn't give 100% immunity to healthcare workers. So we keep on shouting aloud that nebulization is as good as MDI with spacer. So this is the right time to use that.
Sure. So I think the consensus there from all of us is that nebulization as little as possible, not at all ideally, even in patients who are ventilated. Let's try and use this opportunity. The evidence is there that a spacer with an inhaler MDI works as good as a nebulizer. This might be the time window when we make the paradigm shift of going completely to an MDI and a spacer rather than using nebulizer.
And it is almost a 2-decade-old study that the nebulizer is as good as a MDI.
Correct. So point well taken. So quickly, the third question on the sort of COVID, and then we'll sort of leave COVID and go ahead, is about spirometry and other lung function tests in the COVID period. Again, for Rajesh, I think this is actually a straightforward one. So let's see what Rajesh has to say. Rajesh.
So again, spirometry and other lung function test can spread viral particles and expose staff and patients to the risk of infection, it being the aerosol generating procedure. So it's better to avoid spirometry in patients with confirmed or suspected COVID-19. And while community transmission of the virus is occurring, as maybe in our country, it's better to postpone spirometry and peak flow measurements with healthcare facilities unless there is an urgent need. And when it's really required to be done, one should follow contact and droplet precautions. Basically, the spirometry technician should wear a full PPE, changing it after every spirometry, and also detailed proper decontamination procedure need to be followed of the spirometry room post spirometry, which can be quite cumbersome. So it's better to avoid spirometry and other aerosol generating procedures when we have this COVID pandemic.
Right. So thanks, Rajesh. Very concise. I'll ask you guys a thought-provoking question. Kumar, I'll come to you, but let me ask you a question first. So Gold, I think, did us a great service in hindsight now by saying that spirometry is a tool that you use only for diagnosis of patients with COPD. We probably understand that they had more foresight than we did. So that's one. For asthma, we know there are very good questionnaires which can actually tell you information not about lung physiology, but at least about diagnosing asthma. So going forward, I mean, let's think 3 months down the line, 4 months down the line, I don't think we would have rid ourselves of COVID completely. So how do you see recording of lung physiology for chronic lung disease, be that airways disease, be that interstitial lung disease? How do we move forward in this space, do you think? Are we going to go for a symptomatic management, things like 6-minute walk test along with symptomatic management? Or do you think there's a future for lung function tests and lung physiology even in the future, Kumar?
So, Raja, this is, I was about to comment on the same thing which you actually asked. We have to go back to the basic science. And in asthma, we know there is no better marker than peak flow meter, which the patient need not necessarily do in the clinic, but we'll have to start giving them into the houses and they can keep a record. And FEV1 meters are available as well, and which is going to help us in the COPD. The question is, would not doing lung functions under treat or under...
So I've lost your voice for a moment, Kumar. You are space. So can I quickly ask, while we are waiting for Kumar to get unfreezed, can I ask Dr. Khilani quickly? Dr. Khilani, your comment on this? How do you see the future? Crystal ball.
Okay, let me answer this question in a wider perspective. It really depends upon what is the epidemiology of COVID in your area. That means that comes to the question of probability.
Sure.
As far as the diagnosis of asthma is concerned, we know that for the management, the clinical management, the PFT is not sacrosanct.
Sure.
You don't need a, of course, as far as the COPD is concerned, even that FEV1 upon FVC has been given up. And what you assess by doing a spirometry, the severity. What I'm trying to stress upon is that even if there is a slightest risk of COVID in the community, and if you ask me today, we have completely abandoned PFT at this moment in our hospital for the simple reason, because there are so many ifs and buts about transmission of COVID in asymptomatic people. Sure. And even the person is negative, we don't know whether it is true, sure, negative, and so on and so forth.
So Dr. Khilani, sorry, I'm interrupting you, but sort of broad question was, I think this disease, and I'm sure you would...
No, let me give...
disease at some point of time.
15 seconds and I'll...
Yeah, sure, please.
So the answer would be that 3 months from now, it will depend upon the prevalence of COVID in your particular area that will make you decide whether to use PFT or not to use PFT.
Okay. So Indranil, we'll move on and I'll go to the next question because we're sort of moving on in time also. So one of the things, we'll come to GINA now. This is GINA 2019, and this is probably the most important facet of GINA 2019. I asked you a broad question which led to the GINA guidance. Mild asthma is something that has been ignored by GINA for a very long time. But we know that mild asthma also results in exacerbations and the risk is significant. So what in your mind is the risk of exacerbations in people with mild asthma? And if you feel this risk is significant, what is your message to the physicians who are listening to us today as far as mild asthma is concerned?
So Raja, probably much more stress have been given in this GINA 2019 and the updated 2020 on the point of mild asthma. So what GINA has observed is that patients with apparently mild asthma are at risk of severe adverse events. In fact, they have put up with statistics also. In fact, 1/3 of adults who goes into acute asthma are from those of mild asthma. That is, they had symptoms less than weak in the previous 3 months. Not only that, about say 15% of patients who have near fatal asthma is also from the patients of mild asthma. And 50 to 20% of adult dying of asthma is also from the mild asthma. So the huge figure comes to that patients of mild asthma should not be ignored in that way. And its trigger may be anything. Trigger may be the virus, the pollens, the pollutants, or because of the poor adherence. Also because that these patients of mild asthma usually rely on the short-acting beta-2 agonist. They think that on taking the short-acting beta-2 agonist, they feel well. And because of the underuse of steroids or the steroids, they are really poorly controlled in some part of that time.
So the I'm going to ask that question next. So Indranil, I'll ask that question.
So the message you are asking me, the message that should go is that we should not underestimate this mild asthma. We should, and now the GINA is very clear, treat those patients with mild asthma either with inhaled steroid or go for inhaled steroids with formoterol combination. That's the thing.
And that's because there's considerable risk of morbidity and mortality.
And I've given you the statistics for that.
You have given the statistics for that. Wonderful. So come to you, Kumar. Welcome back. We lost you.
I'm sorry.
That's all right. So this was what Indranil had started speaking on. So you can continue from there. What is the problem with short-acting beta agonists? We've used it for 50 years now in the management of asthma. It's always been first line as a rescue medication. What do you think is the problem with short-acting beta agonists, which triggered the change in the 2019 GINA guidance?
I may be politically incorrect in saying that GINA was too slow to get this in.
Sure.
And I would say the problem which we have had all these years of poor control of asthma has been because I might stretch out my limb and say it's because of this policy that we have never started using ICS upfront. The data it's old that excess use of beta-2 agonist leads to death in Japanese patients. It's a very, very old study. There was nothing new in that. And now we have finally accepted that it leads to downregulation of receptors, tolerance, you get rebound hyperresponsiveness. Basically, clinically, what you get is more emergency visits, more exacerbations, and poor control of asthma. And when they compared this with starting ICS in low dose to begin with, the control was better, almost 30-40% reduction in emergency visits, and reduction in exacerbations. In fact, when Dr. Bateman came out with a SMART trial way back, about 8-9 years back before with the turbuhailers, that was a time when we all thought that this is the end game, like single maintenance and reliever therapy. It changed back that SMART is not the right way to go. And then now we are coming back the full circle. I would say that we are there today where we should have been a decade back. SABA as a monotherapy is absolute no. There is down regulation of receptors, there is tolerance, there is rebound hyperresponsiveness, there is increased expression of allergens as well in the same patients. They have even found more eosinophils in the airways of these patients, and thereby single SABA, no. It can worsen your asthma control, increase exacerbations, and plain simple increase deaths.
Sure. So I know Dr. Khillani wants to add to that, but just add my question to you, Dr. Khillani, and you can answer both together because it's in continuation. So the fact that rather than the age-old salbutamol, GINA has recommended the use of formoterol budesonide, both for maintenance and for as and when required treatment. And in step 1, it is always as rescue medications with formoterol budesonide. So what's the rationale? Why not salbutamol? Why the formoterol budesonide in continuation with
my gray hair will tell me, my age and all. The study by Sousa way back in 1980s, late 80s. They showed when the salbutamol or albuterol was used more than 20 puffs a day, there was increased mortality. But the question is that we didn't have formoterol at that time. We got this compound which is rapidly acting as well as it is long acting, so it is being used. there's no question of inhaled corticosteroids as a medication, which is a sheet anchor. If you see the GINA guidelines from beginning to end, the inhaled corticosteroids is there. So now what is your question on that? Is there anything that I need to address?
So basically, we are saying that in step 1, Dr. Khilani, we are using formoterol budesonide as SOS medication. So this is something that was used on a maintenance basis or still used on a maintenance basis in step 3 of GINA. So do you think that we've actually done an overkill by using the combination, the ICS and the LABA as SOS in step 1? Or do you sort of agree that this is the right way forward as we go?
I'm not sure whether it's a right way forward. One thing is that, nobody wants to use 2 inhalers.
Yeah.
And if you ask the practitioners, please name a brand name of inhaled corticosteroid solo, very few will be able to answer that question. You always want to use 1 inhaler and do with that. But that question was to be asked a little later as you had posted it to me. But this actually come little ahead. So when you use a combination of, say, formoterol budesonide at the outset, what you are doing is that you are reducing the dosages of steroids. And there's the studies, Sigma 1 and 2, both have shown that, the rate of exacerbation does not increase. It does not say decrease. It does not increase. But the flip side is that if you see the asthma control by whatever parameters they have taken, the ACR and so on and so forth, it is definitely better with regular use of inhaled corticosteroids. That has to be understood. What it does is that you use lesser amount of inhaled steroids and do not alter the rate of exacerbation. That's the conclusion.
Sure.
And that too with a low dose inhaled corticosteroid.
Low dose.
Sure.
Low dose. So we are only talking about low dose inhaled steroids.
Yeah.
Now the biggest question is, which is right? Is it good to use regular inhaled steroids in a very low dose so that the symptom control is slightly better? Or to use only need-based combination? It's a very difficult question to answer. But if you talk about the ease of treatment, as far as the patient is concerned, then I would prefer a combination used on a need basis rather than the regular use of corticosteroids, which would have its own problems.
So can I ask another question? And I ask this to the entire panel. Dr. Khilani, you have the first go. So suppose you had a choice between an ICS and a LABA, so i.e. formoterol and budesonide, and a steroid and a short-acting beta agonist in combination in 1 inhaler. And we have those choices in our country just now. Which one would you prefer to go for? Would you go for the SABA or would you go for the LABA SOS in step 1?
I will go with LABA and inhaled steroids SOS.
Any differences? Do you think you agree with that, Kumar? Or
absolutely, I would do exactly what Dr. Khilani mentioned, LABA with ICS, but the low dose ICS in the absolutely. I agree with sir completely. That's exactly what we should do.
So Raja, if you go to the GINA guidelines again, there is a option, that other controller option, where low dose ICS is to be given when SABA is taken. Low dose ICS whenever SABA is taken. So how do you take that point?
No. Indranil, okay, Raja can answer that question.
Yeah, sure. It's all right. Kumar, go on. I mean, I'll sort of.
I think Indranil is referring to the earmark thing for the step 3 to 5. Say, in case you are on salmeterol fluticasone combination in step 3 to step 5, which is an approved combination. In such cases, if you have an exacerbation, that time you can take SABA. But if in step 3 to 5 also you are on formoterol budesonide, you can take formoterol budesonide again.
Sorry, Kumar. I am telling about the step 1 in mild asthma. Patients who will be taking SABA should also take ICS along with it.
That's exactly Raja asked.
So I think the point is that GINA says, like all of you have said, all 3 panelists have said, GINA says that whenever you take an inhaler of any description, irrespective of stage of asthma, you should have low rate or high dose of inhaled corticosteroid along with it, right? So I think that is a given.
That is the bottom.
Have said that. That's a very important carry home message for people who are listening. Now the controversy is, if you had a choice, would you have a LABA or would you have a SABA?
SABA.
And I think there are no studies actually for this. There isn't anything which compares an ICS plus a SABA in step 1 versus ICS and a LABA. But our thinking of the physiology is that if you used a SABA, you would be using far more of the beta-2 agonist with all the adverse effects that Kumar spoke about a little while ago. Whereas using a LABA, you would be using a much longer acting version with less requirement of the bronchodilator in the long term, which is why the GINA has recommended what it is recommended.
And not only the side effects of the beta-2, because you are going to have, you will need more and more SABAs that time, you will be taking more and more inhaled steroid in the same inhaler. And thereby your dose of inhaled steroid will also be higher, and which you want to be only the low dose.
Yeah, grand. So I think we agree there. Wonderful. So we'll move on. Dr. Khilani, you have answered the question about Sigma 1 and Sigma 2 trials already.
Yeah.
Anything you want to add to that, or well, shall we just move ahead from Sigma to the next question? Anything?
I think you can move ahead.
Okay. Anyone want?
There are a lot of intricacies in these trials which we need not discuss. The practical part, Dr. Indranil and Dr. Kumar has already emphasized and agreed. I don't think we need to go into that.
Sure. Okay. So my next question, and this is right up your street, Indranil. So Indranil, what are the guidelines about mild asthma in the pediatric population? And if you can outline the differences rather than telling us everything, tell us how it is different to the guidelines in adult asthma. And if you can focus on inhaled steroids in this population, because there's this overriding worry about giving inhaled steroids to children and growth stunting and other side effects. So if you could focus on that, please.
So Raja, considering me to be a pediatric pulmonologist, he has asked me the right question. He was already telling me in the introduction part. So Raja, what the GINA has been doing with the children 6 to 11 years. So we all have already told what 11 years and adult onwards. So 6 to 11 years was GINA has focused in the mild asthma part is that the best thing that they have to do is to take low dose inhaled corticosteroid, because the study with long-acting beta-2 agonist and ICS is less in those people. So what GINA is focusing on low-dose inhaled corticosteroid. That's the thing. And here the low-dose inhaled corticosteroid comes to, see, it is different from that of adult. The low-dose inhaled steroid, if we take the budesonide, which we commonly use, it comes to say 200, not less than 200. There is 100 twice daily, less than 200. So it is focusing on inhaled steroid, not stressing on ICS LABA, and ICS LABA is only focused on step 3 and above in this 6 to 11 years age group. That's my just thing to tell you in the pediatric.
So Indranil, just to repeat myself, so there is an overriding concern about overuse of inhaled steroids in kids, right? And I'm sure you face this question much more than I do. Let me finish. So if you're using the inhaled corticosteroid now, irrespective of stage of asthma, like we are doing in the adult population, the concern is, would you be actually overusing your inhaled steroid in kids and hence increasing the stunting of growth and so on and so forth, which parents are worried about in children?
So to answer your question, inhaled corticosteroid in this low dose is absolutely safe.
Okay.
Had they not been treated with inhaled steroid, the sufferings, the exacerbation that they would suffer, causing much more growth retardation, and ultimately the damage that would be caused by the asthma itself is much more. So inhaled steroids in this dose is absolutely safe, and there are a lot of studies in that. So I can quote you a number of studies.
Yeah. So very important message, Indranil. This is the message I was wanting to convey. I think important to understand that if you don't control asthma and if your asthma keeps exacerbating, the growth stunting that you will have is going to be greater as compared to taking the inhaled steroid even on a regular basis. And I think that's a very strong message. There's a question. I'm getting lots of questions. I've got about 60 questions from the audience already. I'll add one to you, Indranil, because you're talking about this now. There's a question from Dr. Singha about whether it's safe to use formoterol in the pediatric population for a long time.
So again, the study with ICS LABA, in fact, formoterol is to be not to be given alone. It should be combination with budesonide formoterol.
Of course. Yeah, that's what he's asked. Yeah.
So ultimately, if it is to be given, it is to be given from step 3 in this pediatric population 6 to 11 years. And when your asthma is not controlled with low dose inhaled steroid, then you can give low dose in a ICS with formoterol combination, which is also safe. It is not, the few studies that are there shows that it is very safe.
Grand. So it's safe.
So we can give that from step 3 onwards.
Sure. Grand. So Kumar, question for you. We'll move on. We've kept speaking about formoterol budesonide. You've mentioned SMART, the fact that it came and it did not stay the way we thought it would stay. But is there an alternative to formoterol budesonide according to GINA? And if you can also tell us the maximum safe dose for formoterol budesonide and any other inhaler that you might use as both rescue and maintenance. What maximum dose are we looking at?
So as far as GINA is concerned, they have studied only two, that is formoterol budesonide and formoterol beclomethasone.
Correct.
But we have to understand the whole philosophy of treatment. It's just not the molecules. The philosophy of treatment is no monocomponent therapy. It has to be an ICS with a bronchodilator. The point I'm trying to make is if somebody is well maintained in step 3 with salmeterol fluticasone and he has a problem, it doesn't mean that he has to go back to formoterol again. He can take whatever he has again. So the answer to your question, the studies are with only formoterol budesonide and formoterol beclomethasone. But if you don't have an access to any other LABA ICS which contains formoterol, any other thing is also fine as far as I'm concerned. Preferably formoterol budesonide, formoterol beclomethasone. Coming to the dosages which you told me, well, they have found in the formoterol budesonide combination, they went as high as 72 micrograms of formoterol. Personally, in practice, when we go to 48 micrograms of formoterol, people start having cramps and tremors, but they went as high as 72 and they found to be safe from all other aspects, including cardiac toxicity and stuff like that. And in the formoterol beclomethasone, they went as high as 48. I don't have an answer that why in formoterol beclomethasone they went only as high as 48 and why on formoterol budesonide they went as high as 72. It has more to do with the devices which were tested. It was formoterol budesonide was given with a turbuhaler, which was with 6 and 160, and the formoterol beclomethasone was with an inhaler which was 6 and 100. So whatever, as high as they kept on going with the bronchodilator, they kept on going high with the steroid as well. So that could be the only probable reason. But with beclomethasone, they went as high as 48 for formoterol, and with the budesonide combination, they went as high as 72 in the studies done.
Sure. So I'll ask you another question from the audience in a moment, but just to say that formoterol budesonide has long been the favored combination simply because of the rapid onset of action of the formoterol and the fact that there is a dose response of budesonide which is more sharply aligned as compared to any other inhaled steroid that we know of.
Absolutely.
It includes beclomethasone.
Includes beclomethasone.
Factors, but like you said, I completely agree with you, Kumar, that you could use what you want if you don't have access to formoterol.
If you don't have access to formoterol.
Which is first.
So idea is that it should not be because I don't have formoterol, I started using only. Sure. Don't do that. No monocomponents. Agree.
Yeah. So there's a question quickly. I'll ask you that while we are at this, Kumar. So the question is that what dosage interval of SMART in an episode till recovery from formoterol, total daily doses. So I'm reading the question. I'll try and sort of simplify it once.
Yeah.
12 puffs along with low doses of ICS. SABA interval is 20 minutes thrice after episode till recovery. So I think what he's trying to ask, broadly speaking, is when, so you're using SMART, you've used your 12 puffs according to SMART when you have an exacerbation. How would you use the short-acting beta agonist along with it to relieve symptoms? And I don't think there's guidelines for this. So if you tell us what you do in your own clinic.
Is he saying that he has access to formoterol budesonide and he still wants to use this? So the question doesn't arise. We have said no to that.
No, so he said that he's used his 12 puffs of formoterol budesonide.
Okay.
The patient is still not getting over the mild to moderate exacerbation of asthma he has. Now,
so that's a problem with definition, right? Like if he has used 12 puffs and he's still in exacerbation, probably he's in moderate to severe exacerbation where we need to put in
and requires admission.
Oral steroids and requires oral steroids rather than inhaled steroids.
We should stop defining it as a mild exacerbation unless it's an empty canister.
So I think there's an important question which is inherent to that question, Kumar. And the question is, do we now say you do away with your inhaled salbutamol completely, or do you still put your 10 puffs, 12 puffs of salbutamol into a spacer and ask them to breathe in and out through it when people are in an exacerbation.
Okay, haven't we really almost given off inhaled salbutamol a long time back? Even though GINA came down with guidelines now, that's the only inhalers people used to be having with them was formoterol budesonide, and they used to keep on repeatedly. I would stick out my limb and say yes, give it off.
So I will come to you, Dr. Khilani. I know you don't agree, and I would.
That's great to have, right? You need to have this agreement.
I too also don't take with that.
One second.
Completely giving up Saba is
moderator's prerogative. Moderator's prerogative. Don't speak out of turn, please. So I think we'll take my personal softer. I think in patients who have mildly exacerbated or having more symptoms, I would definitely go the smart way. But equally, if you have an exacerbation and you're breathless, I would still put my 10 puffs of salbutamol into a spacer and ask a patient to breathe in and out through it. That would be my take, but I'd like to hear what Dr. Khilani has to say.
It's okay, the new is not necessarily the best, So the thing is that...
Sir, it's old, it's not new.
Wait a minute. Let me finish. For the salbutamol or albuterol, whatever you call, and ipratropium, they are still are the drugs for acute exacerbation of asthma, and we keep preaching and teaching, that if you have a exacerbation of asthma, please start salbutamol inhaler right from home or give it by nebulization even before you reach hospital. It certainly improves the outcome. So therefore, I will not dump salbutamol inhaler as of now, even today for that matter. Smart therapy is going to be there. Formoterol is going to be there. But let me promise you that salbutamol is there to stay for exacerbations.
So I think if we
I'm not selling anything.
Confusing the audience, let's put everything together. My take on it is that the LABA and the ICS, the formoterol and budesonide as rescue medication is here to stay. And with the Sigma studies, we are confident that this works both as rescue and maintenance. However, if your patient is breathless and has a significant exacerbation, I don't think we do away with the salbutamol inhaler. You would definitely use the salbutamol with 10 puffs through a spacer or a couple of puffs through a spacer when you feel that you're using too much of the ICS and the LABA. And like Kumar and Indranil said, I think the oral steroids and a quick visit to the emergency of the hospital is mandated if you're requiring both of these medications, the smart therapy and the inhaled salbutamol. That's my take on it. And we'll move forward with that and come to the next question, which I'm going to ask Rajesh. I think he's still going to give us a recorded answer. So, Shimon, if you can play the answer to the next question, which is very interesting. Montelukast has been with us for ages, but the FDA has given a new black box warning for Montelukast, which is now in the new GINA guidance. So tell us more about this, Rajesh. Tell us more about the new caution on Montelukast.
Yes, Dr. Raja. Montelukast is used widely in our country for asthma with or without allergic rhinitis, and it is usually in combination with antihistaminics, and it is used for a long period of time. But there is an 11-year-old or 11-year duration, actually Canadian study of children aged 5 to 18 years, which was done in Ontario, which found that 898 children experiencing new onset neuropsychiatric events like anxiety and sleep disturbances, which were almost twice as likely as the 3,497 controls to have been prescribed Montelukast in the year before the event happened. And there were some more studies, but with mixed finding. But it is worth noting that US FDA has now given a boxed warning in March 2020 about risk of serious neuropsychiatric events, including suicidal tendencies with Montelukast in adults and adolescents. there are reported nightmares and also behavioral problems in children. So based on these observations, US FDA now wants that before prescribing montelukast, we should consider its benefit and risk, and basically patients should be counseled about the risk of neuropsychiatric events which are described before they are actually dished out this montelukast or this combination products.
Thanks, Rajesh. Wonderful. So let me sort of start off by putting my 2 penny worth into this. So if you look at the Canadian study that Rajesh is talking about, interestingly, it was done in both kids and in adults. And the p-value for neuropsychiatric manifestations was reached only in the kids and not in case of adults. Now, I have used, maybe overused montelukast for years in patients with concomitant allergic rhinitis and asthma, and I have found it to be a very safe drug. I have said overuse too, Dr. Khilani, but I'll let you add anything that you feel from your side about montelukast. Dr. Khilani.
Yeah, I feel very strongly, as everybody think, whenever there is a Th2 type of disease, we think montelukast is a very useful drug.
Yeah.
I'm telling something which is not based on study, it's based on my experience. Somehow montelukast once started is never stopped.
Right.
Not necessarily by the physician, by the patient. And it is our duty as a physician to restrict its use as long as the utility is there. And that is the reason that it is so abused that people are taking it for years, like PPIs, you know. And now we know that PPIs cause CKD. Similarly, if you take drug indefinitely, then this is the result that you get. And I totally agree that in young children, one should be cautious.
Sure. So carry home message for all of us, including myself, is that the montelukast needs to be stopped when the patient is well, when the patient is stable. You can restart it at a later date. And I completely agree. I would own up and say that often the montelukast has drifted on even when the patient has been stable because of this mindset that this is a very safe drug to use. So all of us should probably make
no drug is safe.
No drug is safe. Absolutely. Completely agree, Dr. Khilani. Kumar, quick comment because we've...
the only, this thing is, as Dr. Khilani mentioned, people take montelukast for ages and they don't stop it. In so many times, the combination which they are taking is montelukast, levocetirizine forever and they don't stop it. So that's still worse.
Yeah, absolutely. So Kumar, I'll come to you quickly. I've got 100 odd questions, right? So you're not getting... I know Kumar has had his dinner, but none of us, the rest will have dinner today. So a quick comment about biologics in severe asthma as per GINA. And if you could give us a comment only about anti-IgE and the anti-IL-5 receptor and the receptor antagonist. We'll leave the IL-4 receptor antagonist because it's not available in India. So Kumar, your take on these biologics and when to use it as per GINA.
So as per GINA, it's straightforward. If it's an high IgE disease and we have the table, all of us have the table with us as to when to use it. Two things. The upper limit is 1300 international units of IgE. More than that, you can't give. Less than that, you can give. And it has been approved for children more than 6 years. So, and another thing which you can say that when you start someone on the anti-IgE omalizumab, if it is not working for more than 4 months, it's not going to work further. So you can stop that. As far as anti-IL-5, which is available in our country, mepolizumab, which is available, it's a monthly dose and it's more for an eosinophilic disease. If you have your blood eosinophil count more than 180, you can give that. And the results are more than 50% reduction in exacerbations. It's working on two different pathways. One is the eosinophilic pathway, one is the IgE pathway. Basically, we will need to phenotype our patients, whether it is a eosinophilic disease or whether it's an IgE disease. And depending on that, we can give the patients. But the eosinophil levels for the mepolizumab are also not that high. I would say most of our patients will have that cutoff limit, which is recommended for mepolizumab, and they would probably be a candidate. Of course, the problem is always the cost factor in our country.
Sure. So very quickly, Kumar, I think you put it great, but just to summarize, we are talking about two different pathways as Kumar said. The eosinophil and the other is the IgE. Drug of choice when you've got a raised IgE and a normal eosinophil is definitely omalizumab. When you have a raised eosinophil but a low or a normal IgE, your drug of choice would be the interleukin 5 receptor or the interleukin 5 antagonist. When you have both raised, you have a raised IgE and a raised eosinophil count, you have a choice between the anti-IgE and the IL-5 receptor antagonist. When you have both low, there is very little that you can do in the way of drug therapy, and you're left with maneuvers like bronchial thermoplasty, low-dose macrolides in treating these patients, and that is the wisdom even from GINA. So that's the...
So you phenotype them two ways. You phenotype them sputum-wise and you phenotype them blood-wise, whether neutrophilic, eosinophilic, and blood eosinophilia and IgE.
Sure. So I think sputum eosinophilia, as you all know, is difficult. Sputum is difficult. So I think for this audience and for the talk and for GINA, we are sticking to blood eosinophils here. That's what we are doing. Sputum eosinophils definitely has its space, but it's challenging to do throughout the world. So quickly, question for Rajesh and Shimon, if you can play the next question or get ready to play the next question, which is about patients who have concomitant asthma and COPD. There's been lots of GINA updates about this. You've had the ACOS syndrome, you've had the ACO disease, and now you have concomitant asthma and COPD. So Rajesh, what's your take on this?
So this GINA update says that ACO, as we all know, or asthma COPD overlap, or asthma plus COPD, it is not a single disease actually, but basically a descriptive label for patients commonly seen in clinical practice. And as we know that asthma and COPD are heterogeneous and overlapping conditions, and the definitions of asthma and COPD are not actually mutually exclusive. Each includes several phenotypes that are likely to have different underlying mechanisms, and there is increased interest in the potential for actually precision treatment for them. So, but however, the labels asthma and COPD are still clinically important as evidence supports safety-based differences in treatment recommendations, like for asthma, never treat with bronchodilators alone, as there is of course risk of death, hospitalization, and also risk of severe exacerbations. And similarly for COPD, you have to start treatment with LABA and or LAMA without inhaled corticosteroids. So patients with diagnosis of both asthma and COPD are more likely to die or to be hospitalized if treated with LABA versus ICIS and LABA. High-dose inhaled corticosteroids may be needed for severe asthma, but should not be used in COPD because of risk of pneumonia. So, in short, by careful history taking and spirometry, we should decide if in this asthma COPD overlap, which is the predominant component, whether asthma or COPD, and treat it accordingly. I think that would be the best approach to have management of this echo or asthma COPD overlap.
Yeah, so very quickly, we have actually run out of time. We need to take some questions, but I think what Rajesh was saying there is it's important to find out whether the patient has a phenotype of asthma or not. So ask the right questions. Make sure you're not missing asthma, because if you're missing asthma, the patient misses out on the most important drug for asthma, which is inhaled corticosteroids. Because as you know, the evidence is emerging and we are going overboard with talking about bronchodilators in the management of COPD. That's not a wrong thing to do, but with dual bronchodilation, you don't give the patient the steroid. And if your patient happens to have concomitant asthma or has the ACO syndrome, you can call it what you want. If you don't give them the inhaled steroid, it is going to cause exacerbations and deaths due to the underlying asthma. I think that's the important carry-home message we have for the audience there. So next question is for Dr. Khilani. Dr. Khilani, again, right up your street, your area of passion. GINA has made a passing reference to high concentration oxygen. So acute asthma, Dr. Khilani, give us your take about high concentration of oxygen that GINA has mentioned in its guidelines this time.
So The same thing which I'll take it from ECOS, the difference between COPD and asthma. This high concentration comes from the COPD, because in COPD you don't give high concentration of oxygen because there's a risk of hypercarbia. Whereas in asthma, we always teach from the beginning, you should be liberal with giving oxygenation. But the previous day of liberal oxygenation is gone. But you give oxygen, you don't be conservative with oxygen. So high concentration of oxygen, you are not worried about over-oxygenating these patients. You want to give, so that's fine with me. I have nothing to add on that.
Okay, grand. And we'll reach the end of the questions we had in Renil. So a question for you. What are the factors contributing to the development of asthma which have come in as new in the GINA guidance from 2020? And if you can briefly tell us how this is especially important for an Indian clinician seeing patients of asthma. Indranil.
Thank you, Raja. So if you see the global prevalence of pediatric asthma, in the last 50 years, it is increasing. And now it is one of the most common cause of non-communicable disease among the pediatric age group. So they have come up with some reasons, the factors, and the odds ratio also. The first thing is obesity. So obesity is thought to be one of the risk factor. And for this, they have cited a very good study from the dengue, which has reviewed or the meta-analysis of 18 articles with more than 75,000 pediatric population, where they have come up with the odds ratio of obesity and wheezing and obesity or asthma. So obesity of wheezing, the odds ratio is 1.9, whereas obesity with asthma comes to 1.3. Sure.
So obesity is important. What about the Indian perspective? What do you think sort of?
Again, Indian perspective. This study, the meta-analysis didn't include some of the Indian article, but still in India, we do see pediatric obesity is increasing to some part of the country, mainly in the urban part where they are eating junk foods and fast food. So that should be avoided a good healthy diet is what is important. Again, malnutrition is another important cause, but practically obesity in the developed countries is very important.
Anything else
next important thing is that about the traffic related air pollution. They have shown that 13% of the global asthma in children is because of the traffic related air pollution. And for that, the study that has come up in Lancet, they have cited that with more than 154 countries participating, and one of the surrogate markers being NO2. And they have shown mainly in the urban that because the NO2 rise is associated with increase in the asthma and the tune of 13%, they have already quoted it. So in India, again, Indian perspective, you can tell that because of the increase in the pollution, mainly in some of the cities like Delhi, Calcutta, or some of these cities where the increase in pollution is there, so pediatric asthma is increasing. And again, the WHO limit for this NO2 in pediatric is to be reviewed, because they have also shown that in some of the places where it is below the WHO standard, but still they are having the symptoms. So the WHO standard may have to be reviewed. That's the important.
Quick comment, Dr.
Everything in WHO needs a change.
Yeah. So
everything in WHO needs a change.
Including COVID.
In the intensity of talking about formoterol and inhaled corticosteroid, we have totally forgot about theophylline. And I would
absolutely.
I would like to talk about it a little bit.
Of course.
Because
there is one question on that.
We have got questions on oral theophylline, Dr. Khilani. So it's absolutely pertinent to talk about.
So there are a few things that I would like to say. One is that sometimes it is impossible to discriminate between asthma and COPD. One. Number two, long-term asthma, we all say it becomes remodeled and then it behaves like COPD. Third thing, that now we know that theophylline have not only a bronchodilator effect, but several effects on mucociliary and
anti-inflammatory also.
Anti-inflammatory and respiratory stimulant. And fourth thing, that we know that lower dose of theophylline, that means blood levels of 5 to 10 milligram per liter, are as good as previously what we used to say 10 to 20 or 20. In what I'm coming to is that low dose of theophylline is good. It is inexpensive. You are sure about the delivery as compared to the inhaled drugs, which you are always, you have doubt whether what is going. And all of us know when you actually ask the patient to demonstrate the inhaled drug, very rarely you find a person using it in the ideal. So therefore, my take is that theophylline has a role, especially in our country. You know, we are in metros, but you know, the India lives in the rural areas also. So the role is in uncontrolled asthma, very little. It has a role in ECOS,
COPD.
Role in COPD. That should be emphasized, and whosoever has asked that question, I thank him for asking that question.
So thank you very much, Dr. Khilani. So carry home message. We are not saying theophylline is a replacement for inhaled drugs.
No.
Drugs are important, very important. But what Dr. Khilani says, very important, ACO, COPD especially, maybe not so much in asthma, that the evidence is weak in asthma, but especially in ACO and COPD, there's a definite place of low-dose COPD, low-dose theophylline. A question which I think is absolutely appropriate for you, Dr. Khilani, I'll sort of stick to you. So there's a question about the use of these guidelines when you practice asthma in a rural setting, which I find fascinating. What's your take on that?
I would cite a statement by ATS IDSA guidelines, which are in the form which is in the context of the guidelines for antibiotics in ICU, which I preach. They always say that antibiotics are there, but they are not there to supplant the clinician's decision. So therefore, everybody should know the guidelines, everybody should have the knowledge, but it has to be used in the context of the clinical situation and the local scenario. In view of that, in the rural setting, I'm not saying that inhalation therapy should not be used, it must be used. India is changing. The Indian rural is no more the rural what used 30 years. Everybody has television, everybody has a mobile phone. But the fact of the matter is that economy is important. Everybody cannot afford inhaler. That's why I brought up the issue of theophylline. And I'm not saying that you should use it at the outset. Don't get me wrong. Other thing I want to say, and since you have permitted me some time, is use of long-acting muscarinic agent. Whenever you have an ECOS, then that would have a prominent role to play.
Raja, one thing is very good, that we are still getting ICS lava from government supply in the rural setup. We do not get this Saba, but we get the ICS lava from rural hospitals also. That's the good
Which is great, isn't it? I think what Dr. Khilani says, what Indranil says, I think my sort of take, and I'm sure Kumar's take also on this, is that you don't really need to treat your asthma differently in the rural sector.
Absolutely.
You have good quality ICS lava, which is available throughout the country in the most remotest of areas. And the carry home message is inhaled corticosteroids are by far the most important drug wherever you treat asthma throughout the world. And that should be a part of your treatment regime, irrespective of where you're practicing. I think that's very, very important and something to be taken across. I have a question that I'll answer if that's okay. So newer treatments for resistant asthma, Dr. Kukreja has very kindly asked. And I think I'll leave it with a comment. We have talked about this today. So all of the biologic treatment that we talk about today is relatively new. Omalizumab has been there for more than 10 years, but mepolizumab is a new drug. There are other biologics which are on the anvil. There's also things like bronchial thermoplasty, which we have spoken about. But I think more than drugs, and there are many more drugs which are going to come in, but much more important than the drugs is the concepts that we spoke about, which are new. I think the concept about treatment of mild asthma in step 1 and step 2 of GINA with the ICS and LABA is something which, like Kumar said, should have been done ages ago. And we have actually missed the boat in mistreating a lot of people and not giving them the low-dose ICS. I think what the concepts are more important than the actual drugs. The drugs are important, but I think we have effective drugs as of today to treat asthma anyway. There's a question I want to ask you, Kumar, quickly. Question about LABA extra. So what he's asking, I think, is that LABA being long-acting, do you think using LABA regularly might cause more tachycardia as compared to using the SABA SOS? We have discussed.
No, it doesn't. It doesn't.
Yeah.
It doesn't do. It has been shown and it has been practically observed. There is a short-acting which gives rise to more tremors and more tachycardia than the long-acting ones. So it doesn't. It's plain. But I had a comment continuing on Dr. Khilnani's comment on theophylline. We have been following the world and we have been following the West since long time. And I don't think anyone in the world has more experience in theophylline than all of us in the country.
Sure.
Isn't it time for the Indian Chest Society to take lead and
Yep.
reposition theophylline in the therapeutic role of asthma? I'm
So
not
I'll
talking
tell you
of
something. So I'll tell you something. We started a trial, Dr. Khilani and Kumar, very interesting trial, which involved Australia, South America, and India, which looked at low-dose steroids plus oral theophylline in rural areas, in impoverished areas for the management of asthma. The study started and died a natural death because the sponsors got disinterested in a study where the cost of the drugs was peanuts. So I think that's the challenge. We started it with a lot of vigor.
No, but that can be a consistent statement, and we need to reschedule, reposition the drug. We all are using it. I
completely agree. No, I completely agree.
But we don't have, the position is still probably not the right.
Sure. Indranil has disappeared. I was going to ask him a question, but I'll ask it to you, Kumar. So in similar lines, no, he's
come back.
Question for you. So role of doxyphylline in asthma compared with derifylline is something Dr. Anand is asking. So doxyphylline rather than derifylline in asthma. Quick answer, please. Indranil, you're on mute.
Yes, I'm there. So see, if should I answer this question?
Yes, please. Your question, please.
So doxyphylline is a safer drug placed to derifylline. So if you have the option, you can choose doxyphylline over derifylline. And again, in the asthma population, it should not be replacing ICS. Definitely, it should be an add-on drug with ICS.
Indranil, I might just increase this person's panorama of question. What would be the doxyphylline equivalent of derifylline dose? Say he's using derifylline 150 BD. What becomes the doxyphylline dose?
400 BD.
That's what he needs to know that. That's right.
So it's a standard dose that we normally give. If you are giving low dose theophylline, it's the 300 milligram OD preparation or the 150 twice daily. Or if you are giving doxyphylline, it is 400 milligram twice daily. That's the normal standard. Or even we have once daily doxyphylline right now.
Thank you.
So Raja,
question, right? Yes.
Raja, a very important question which I think you should answer: the role of FeNO in choosing biologics. That's a really bonding.
I'll answer that, but I'll ask a question which is right after Kumar's heart. Kumar, role of tuloplast in COVID suspects. That's
in the morning I was asked the role of papaya juice in COVID. So so that answers your question.
So can you tell us, I mean, jokes aside, what about, do you believe in these alternative transdermal patch bronchodilators that have come up? I'm not a believer. I'll start off, I sort of put my hand up and say, I don't believe in these drugs.
I think, Raja, at the outset only, we removed SABA out of equation.
So tuloplast is a transdermal patch,
which is a bronchodilator
for use in COPD.
It's a long-acting,
but it's a long-acting drug. So
I'm not a very great fan of that.
Yeah,
I haven't, to be very honest, I haven't used it at all.
Dr. Khilnani?
No experience, no knowledge.
No experience. Okay.
No experience. Came in the market and went off, and in fact, no question in asthma.
Okay, very good. So that's the bottom line. Thank you. So quickly, FeNO, so exhaled nitric oxide. So in my understanding, there are 3 uses of exhaled nitric oxide in asthma. The first is if you have a patient who has a phenotype of mild intermittent asthma, and if you have a spirometry which looks normal, because you're doing it when the patient is relatively stable, as you would do, a FeNO is a good surrogate marker, and a significantly high FeNO, a level of over 25 or ideally above 35, shows ongoing airway inflammation. So that's one use. It's a weak indication for the use of FeNO. The second indication, which is a stronger indication, is to step down on the dose of inhaled corticosteroid. So situation in which the patient is relatively stable on a dose of inhaled steroids for a period of 3 to 6 months. If you want to step down on the dose of inhaled steroids, FeNO is a good tool, and a FeNO of less than 20 is thought to be indicative of stability of airway inflammation. That's second. The third indication, which was the question really, is about its use for biologics and for especially the IL-4, IL-13 antagonists, the receptor antagonists. A raised FeNO and serum periostin are supposed to be the best markers to predict response. However, even for other biologics like mepo and omalizumab, certain FeNO cutoffs have been given. A low FeNO for omalizumab and a high FeNO for mepo is thought to predict response. So that's the answer for FeNO.
Absolutely.
Yeah. So there's a question I want to ask Dr. Khilani. Dr. Khilani, Dr. Trideep Chatterjee. Hi.
Rajesh, join. Hello, Rajesh. Welcome.
Hi. So Dr. Khilani, there's a question from Dr. Trideep Chatterjee. In a hospital setting, a single nebulizer is shared among patients when there can be a maximum danger, especially on the general wards. I know your take on this, but I want you to repeat it because I think it's a message that needs to go across strongly.
No, this is the nebulization is a very important source of cross infection. It's not only among the two patients; it also had healthcare workers. And today's era, it is very important. So the mask and tubing have to be cleaned and sterilized before using it for another patient. All care should be taken. And I would say, as far as COVID, I said at the outset, nebulization, big no-no, non-invasive ventilation, big no-no for all this patient. And my interest is in ventilator-associated pneumonia and all those things. So I'm very, very, very skeptical about. In fact, when I treat my patients in the hospital, I generally ask them to bring if they have nebulization at home, I ask them to bring that nebulization so that they don't use nebulization from
right. Thanks, Dr. Khilani. That's a strong message for everyone. So Rajesh, I cannot but ask you a question. We are at the fag end of this meeting. We'll finish in the next 2-3 minutes, but I have to ask you a question. This is in line with the Montelukast question you answered for us a little while ago. So there's a question about a combination of Montelukast and levocetirizine versus Montelukast plus fexofenadine in a patient with bronchial asthma who's pregnant, and the person who's asked the question, Dr. Gururaj, wants a trimester-wise answer. So first, second, and third, what do you think is safe? What do you think is unsafe?
So I think for the first trimester, I would not use, in fact, any drug apart from inhaled drugs. Those are quite safe. So usually in the first 3 months, we don't use actually much of oral drugs as far as possible. So, I should tell that even also in all trimesters of pregnancy, we can use inhaled drugs, inhaled corticosteroids, and there's no need to use, in fact, tablets at all. But if suppose there is a need, then of course you can basically use a single Montelukast, without any combination, and after that too, not for more than 2 to 3 months, I think, if it is required.
And all of these, so drugs like fexofenadine and levocetirizine are class C drugs, isn't it? So you caution, not enough evidence is the bottom line.
One thing is important. When he's telling it's an asthma patient, why should we really need for a Montelukast?
Montelukast, yes, because it's an additive. It's an additive drug.
I think he probably means there's also concomitant allergic rhinitis.
Allergic rhinitis. So there is other drugs. Intranasal steroids is there. You can use.
Intranasal corticosteroids.
So I think it's probably time to finish our panel discussion, simply because we've started getting a lot of questions on immunotherapy. I know when that starts, it's time to actually
controversial subject.
But if I can have a quick comment, I will open this to anyone who volunteers answering. The questions are about immunotherapy, when and what in asthma, about skin prick testing, what is the guidance, and about desensitization. I've clubbed 3 questions together. So any takers at all? Stony silence. So I'll answer by.
It cannot be answered in 5 minutes. It cannot be answered in 5 minutes. That's the real thing. It will take a whole session to answer that answer.
So I'll answer that in 30 seconds. My 2 penny worth. My knowledge is actually worth only 30 seconds. So I'll give you that. So the problem with immunotherapy in patients with asthma is the fact that you have to have an FEV1 which is above 70%. That's the license for use of immunotherapy in patients with asthma. Now you understand that if you have an FEV1 of more than 70%, why would you in the first place not use an ICS and a LABA, which are proven effective treatment for patients with asthma? Now there's a counter argument that with immunotherapy, you can actually have a cure of asthma. You can probably come off inhalation therapy over a period of time. And I think the combined wisdom of all of the panelists in this room is probably not enough to try and have an argument about immunotherapy vis-a-vis conventional inhaled treatment in management of step 2 and step 3 of asthma. That's my take on it. If anyone wants to add to that, please go ahead.
When it comes to skin prick test, Raja, probably a patient whom we think allergic asthma is there, I may move on for a skin prick test to identify whether it is allergic asthma or not, and to find out the triggers, what the triggers are. So skin prick test is something which I normally advise or do, but not the immunotherapy part. But skin prick test sometimes may help me to distinguish, and also for the role of biologics, if I need to give biologics, whether I'm confident with the treatment on that's
so
the thing.
last couple of questions, one for you, Indranil, and these are definitely the last two questions, fascinating questions. So there's one question that you have someone who has a child with recurrent episodes of wheeze or childhood bronchitis. If they have recurrent exacerbations, would this get converted into bronchial asthma at later age or not, is the question.
So again, there is a real hot topic in this. So a child, the probability of developing asthma in later part of his life depends on some factors. For example, the features of atopy, recurrent episodes of wheeze, which is usually afebrile, lasting for more than 10 days, more than 3 times in a year, with a strong family history. These are something which guide us to tell us that this child may develop asthma in the later part of his life. That's the predictive index for asthma. And there are some few important things that we should remember. These few things: atopy, more than 10 days, afebrile, persisting more than 10 days, 3 times in a year, more than 3 times in a year, and strong family history.
Sure. So I have to give the last question to you, Dr. Khilani. Fascinating. I'll ask you a broad-based question. There's a specific question here, but the question is, if you have someone who's got occupational asthma or has asthma because there's an occupational trigger to his asthma, and there's a challenge with re-employment for this gentleman, he cannot leave his job and go away. So what do you do in such a scenario when the trigger lies at work and the guy cannot actually leave work and go away? What do we do in this scenario?
Why did you ask me such a difficult question? So it all depends upon what is the occupation, how much is the severity, whether he has a atopy, whether he has concomitant allergic rhinitis, and what is the response to therapy. All these 5 things will have to be considered. If the asthma is very severe and he cannot live with it, and there's no doubt about it that he has really have no choice. But that kind of situation, and plus of course smoking, active as well as passive smoking, which is known to all the factory workers, the smoking incidence is very high. Having said that, it doesn't stop here. The use of respirators, as we commonly call as mask, and trying to change the environment at work, trying to minimize the exposure. Like suppose somebody is working in a factory where there's a marble cutting going on, you do wet cutting, so on and so forth. A lot of things can be done to actually minimize the exposure if we cannot change. I can understand change of job could be difficult. So cutting down, no smoking, active or passive, cutting down the exposure, optimizing the therapy depending whether it's actually it is a COPD or actually it is the atopic type of asthma. All these things will go a long way, and of course the regular pulmonary function tests to know as to how badly it's getting affected. I know these are all political responses, not very accurate.
No, I think that's a great answer. So my take, Dr. Khilani, from what you said is that if you so if you cannot actually control your asthma, your occupation, if you cannot change your occupation, that's a definite trigger.
To minimize the exposure, change your, in the same organization, change your role, And all those things can be done.
And control everything else, make sure you're on optimal medication. That's all we can say.
And no smoking.
And no smoking, correct. So very quickly, one-liners, please. I'll interrupt you if it's not a one-liner. Carry home message from the GINA 2019 and 2020 guidance. Start with you, Rajesh. 1 or 2 lines max, please. We need to finish. Rajesh.
So I think my take-home message, in reference to the ongoing COVID pandemic, is that inhaled corticosteroids are safe to use even in this COVID-confirmed cases.
Sure.
But of course avoid also starting oral steroids for one of the milder cases of asthma. So that would be my take, and avoid also nebulization as far as possible.
Sure.
And use MDI with spacer.
Sure. Thank you. Indranil, one message.
So do not underestimate the mild asthma. They may turn into severe. Do treat them with ICS at least, or a combination of formoterol with budesonide. And again, the obesity and this road traffic pollution is to be taken care of whenever possible.
Thank you. Kumar, you got your audio off.
Muted. Audio muted.
Your audio muted. Yeah.
Unmute your audio, Kumar. So
unmute now.
Let's.
No monocomponent therapy.
So sorry. Come again.
No monocomponent therapy.
No monocomponent therapy. Okay. So when you say no monocomponent therapy, you mean no monocomponent bronchodilator, or you're also against monocomponent ICS? Is that what?
No, we have no role of monocomponent ICS any longer. Right from step 1, we are on 2.
Okay. Okay. And Dr. Khilani.
So my take is 2. 1, whatever you may do, we know the treatment. Whenever patient comes to you, please witness how he is taking his inhalers. That I think is most important thing. And second take is that Raja, you are great. It was amazing.
Thank you. And my take, Rajesh, is that from the questions, we probably need to do at least one more session on COVID, which questions and answers, because the questions, and I'm sorry, very sorry to the audience, the questions that I've actually missed out on are the COVID questions. We've done the COVID tutorials which are available, but I think we need to do another one. So a big heartfelt thanks to every one of the audience who's listened in to us and asked questions. Big thank you to Rajesh, Indranil, Kumar, Dr. Khilani for having participated so enthusiastically. We've even had arguments. So thanks a lot. And I'll let Rajesh thank the ICS before we finish. Rajesh, over to you.
Yeah, thank you, audience. And basically, we are having these COVID seminars and webinars. As I said, webinars are the things to stay now. And I think you would just look forward to much more, I think, COVID seminars and also other webinars from Indian Chest Society. We would also save these questions because we'd also be revising asthma guidelines. So I think whatever questions you ask, we'll just collate it into and basically a document. And we'll also delve into it whether I think we'll just go for this also revision of asthma guidelines. So thank you, audience. Thank you very much, and we'll be back again soon. Thank you.
Thank you all.
Bye. Bye. Bye, everyone.
Thank you. Thank you very much.